Good afternoon, everyone. Good afternoon, everyone, and welcome. My name is Calvert Tisdale, and I am a postdoctoral research fellow at the National Drug and Alcohol Research Centre, and I am lucky enough to be chairing the webinar today. Thank you, everyone, for joining today. I'd like to give a warm welcome to everyone in the audience. That includes many different and important perspectives, including clinicians, researchers, people with lived and living experience, and of course, everything in between, such as community members and other health professionals. So thank you for joining us. Before we start the webinar, I would like to begin by acknowledging the Bidjigal and Gadigal people as the traditional custodians of the land from which I am joining this meeting today in Randwick, in Sydney. I would also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across Australia, and pay my respects to the elders past, present, and emerging, extending that same respect to anyone who is joining us is a First Nations person as well. Today, I have the distinct pleasure of introducing Megan Wells, who is a PhD student at the University of Wollongong and also a clinical psychology registrar. Megan's research focuses on AOD treatment for adolescents and emerging adults, with a focus on examining the youth-friendliness of AOD treatment and enhancing services responsivity to young people's needs. She'll be able to talk about it a lot better than I will. And she is joining us from Tasmania today, so there may be some connection issues, but we're hoping we can make it through without any. Following Megan's presentation, we are also lucky enough to be joined by the primary supervisor of Megan's PhD, Associate Professor Bryony Lawrence. Bryony, who is currently at the School of Psychology in the University of Wollongong, conducts research examining strategies to reduce the harms associated with illicit drug use and innovations in the treatment of substance use disorders. Her work intersects psychology, addiction, medicine, pain medicine, psychiatry, and public health, applying innovative research methods to undertake prospective cohort studies, clinical trials, post-marketing surveillance studies, and analyses of linked administrative data. And that is all done to generate critical knowledge relevant to health policy and clinical practice. So we're very lucky to have both of these speakers today. Before I introduce Megan, I would just encourage everyone to use the Q&A function at the bottom of the Zoom screen and put your questions in there. And I will try to ask as many questions as possible during the Q&A that will follow directly after Megan's presentation. So I'll now invite Megan to turn on their camera for me, please. And I will hand over to you. Thank you, Megan.
Cool. Thank you so much, Calvert, and thank you everyone else for joining in today from all over Australia. My name's Meg. I'm a PhD student at the University of Wollongong. I'm also a clinical psychology registrar, and I've also recently began a postdoc research position, which is why I'm joining from down in Tasmania today. And I'm going to be presenting today the body of work that made up my PhD, which is in the final write-up stages at the moment. We're looking to submit over the next couple of months. Before I begin, I would like to acknowledge the traditional custodians of the lands that we're all meeting from today, including the traditional custodians of the Dharawal land up in Wollongong, which is where I was living and working while completing the research that I'm going to present today. I'd also like to acknowledge all of the many people that contributed to the research that I'm presenting today. Of course, my supervisors, the co-authors on all of the papers that we've been working on, the custodians of the data that we used for some of the research, and of course, all of the clients who contributed their data to our research. We wouldn't have been able to do it without their cooperation and input. I do want to acknowledge as well that I was supported by an Australian government scholarship while completing this work, and that the research was supported by the Mo CRE. So to begin, I thought I should give a little bit of background about why it's important to look at youth drug and alcohol treatment specifically. I'm assuming that probably everyone who's joined in today is aware that drug and alcohol treatment is important, Why might it be particularly important to look at young people as a specific and separate population? The first thing is that emerging adults and adolescents are really key periods for the onset of substance use and also the onset of substance use disorder. So we see really high rates of transition during these life stages of transitioning from what we might think of as experimental substance use or recreational substance use into those more kind of hazardous or harmful patterns of use that we think of as a substance use disorder. We see that the peak onset for substance use disorders is in those late adolescent, kind of late teenage years. And we also see that people who are aged 16 to 24, so these adolescents and emerging adults, have the highest prevalence of substance use disorder compared to other age groups. So it's really important here to be looking at treatment, both in terms of the high prevalence of substance use disorders for this group, but also thinking about early intervention, thinking about onset happening during this time. It's really important to be intervening during these early years. We're also aware that adolescents who develop substance use disorder symptoms are susceptible to long-term substance use disorder that persists well into their adult lives, and also long-term substance-related harms. So again, it's an important kind of population to be looking at if we're thinking about reducing long-term harm. And then from a policy perspective as well, youth are identified in Australia in our National Drug Strategy as one of the priority populations in terms of alcohol and other drug treatment, alongside some other populations, including Aboriginal and Torres Strait Islander communities, and our LGBTQIA+ communities as well. So in Australia, it is recognised, I suppose, the importance of looking at this population. And then potentially the most important thing is that effective treatment during adolescence and emerging adulthood is really important to be able to disrupt the pathway into that more kind of chronic or relapsing pattern of use that we so often see associated with substance use disorders. Given that young people may have shorter histories of substance use, they might have not experienced the same extent of substance-related harms as some of our older AOD treatment clients. So it is really important to kind of improve long-term quality of life and improve long-term outcomes. Before I continue, I think it's important to just touch briefly on definitions. Definitions of youth have evolved over time, and they're used, these kind of terms about like adolescents and young people are used differently, both in the academic literature, but also just in kind of day-to-day discourse. So for today, just for clarity, when I'm speaking about adolescents, I'm speaking about people that are aged 10 to 17 years. Emerging adults, I'm referring to as those aged 18 to 25. And if I'm speaking about youth or young people, I'm speaking about both of those groups collectively. So that's a little bit of background around why it's important to look at youth drug and alcohol treatment. I guess the next thing is to think about what that actually looks like in practice. It's quite widely accepted now that young people do have unique needs and that healthcare services need to be responsive to those unique needs in order to be appropriate for young people. So we can't necessarily take the same models of care or the same ways of working that we use with older clients, apply them to young people and expect them to work in the same ways. So to kind of help disseminate quite broadly youth-friendly healthcare services, the World Health Organization has put together some guidelines around what youth-friendly healthcare is. And this is applicable to not only drug and alcohol services, but also mental health services and physical health services more broadly. And the World Health Organization guidelines kind of fall under 5 key headings. And while these 5 areas are important to look at for all populations of people in substance use treatment, they provide some specific guidance around how those principles should be applied to young people specifically. The kind of principles that we're thinking about here are accessibility. Young people need to be able to get into the service. They need to be acceptable from the perspectives of young people. They need to be equitable, so not just tailored to one group of young people, but easily accessible across the board. They need to be appropriate, so tailored to the unique needs of young people. And they also need to be effective, and that evidence base needs to be, they need to be evidence-based in youth populations. We also have a couple of systematic reviews now that have been completed, looking at what actually constitutes youth-friendly care in the drug and alcohol and the mental health sectors. And they've identified a couple of kind of consistent themes across the literature. The first is identifying that it's important to involve young people in all stages of service development and delivery. And that includes being active participants in their own care, so supporting autonomy and that sort of thing. It's also really important to have clear confidentiality policies, particularly when we're thinking about adolescent clients, who might be under 18 years old. What does confidentiality look like for those clients? Being really clear about what the policies are and communicating those clearly as well. It's important also to have integrated and wraparound supports, especially knowing that young people may not have knowledge or experience with navigating the healthcare system, which can be quite complex and quite confusing. So supporting them through multidisciplinary support and kind of one-stop shop approaches is really important. Having youth-appropriate environments and communication strategies, which is things like using technology in an appropriate way, having non-clinical feeling environments, having approachable staff who know how to engage with young people and feel friendly and not intimidating, really approachable. And then finally, thinking about convenience and low cost, knowing that young people may not have a lot of disposable income. They may also not have access to a lot of transportation to be able to travel long distances for services. So thinking about that convenience and that accessibility for young people is really important too. So I guess that's a bit of background around why it's important to look at this population and what youth-friendly care should look like in theory. That brings us to the start of the body of work that we've conducted. And to start this work, we wanted to understand what AOD treatment looks like in a broad sense for young people in Australia, to really start to understand the population and the treatment systems that we were thinking about. So to do that, we decided to look at national trends in treatment episodes, in particular looking at trends in principal substance of concern and planned treatment completion. And then we wanted to compare those trends over time between adolescents, emerging adults, and other adults. When I'm speaking about planned treatment completion here, I'm referring to those episodes of care that are marked as being completed as planned, rather than having other reasons for treatment completion, such as like leaving against medical advice. So our data for this study was drawn from the Alcohol and Other Drug Treatment Services National Minimum Dataset, the AODTS NMDS. And we were looking at closed treatment episodes that were initiated between 2003 and 2020 for a client's own drug and alcohol use. Using those criteria, we ended up with a sample of 2,900,000 around about treatment episodes that were initiated between 2003 and 2020. And I do want to note here that treatment episodes were the unit of analysis, not individual clients. So we may have the same people presenting multiple times in this sample. Across that time period, we had about 20% of our treatment episodes were provided to emerging adults, around 6.5% were provided to adolescents, and the vast majority, as we'd expect, were provided to adults aged 25 and over. And in terms of our analysis, we used join point regression modelling to characterise trends over time in those key variables of interest, so treatment completion and primary drug of concern. So here we have the results of that joint point regression modelling. And this slide here is looking at principal drug of concern. And it may be a little bit difficult to see, I hope it's okay, but the blue line represents adolescent treatment episodes, the green is the emerging adults, and the red is the adult episodes of care. And what we could see is that for the emerging adult group, there was some change and some fluctuation between 2003 and about 2014 or 15 in primary drug of concern. But from that point, from about 2015 forward, it was pretty stable. And from that point, what we saw was that for emerging adults, cannabis was the principal drug of concern for around 40% of treatment episodes. Psychostimulants accounted for about 30%. Alcohol was about 20%, and opioids were the next most common, and they were down at around 3%, so much less common in this group. For adolescents, the trends did look a little bit different. We saw a much higher proportion of episodes that were targeting cannabis use, so you can see that blue line in the cannabis graph. And we also had a much lower proportion that were targeting psychostimulants. We did see a bit of a difference in alcohol-focused treatment episodes as well, where for the emerging adults, it seemed to, the proportion of episodes that were targeting alcohol use for emerging adults seemed to kind of decline and then level off from about 2015 onward, where for the adolescent sample, it continued to decline throughout the rest of the study period to 2020. So this next slide then shows the trend in the proportion of treatment episodes that were completed as planned. We know that planned treatment completion is not a perfect measure. There's lots of other factors that should be considered when we're thinking about whether someone's treatment is considered successful. But in terms of large, routinely collected data sets, often planned treatment completion is the best measure that we have of successful treatment. And there is a pretty good evidence base that suggests that people who complete their treatment or who stay in treatment longer have better outcomes than those who disengage early or don't complete their episode of care. So although it's imperfect, it did seem like it was a worthwhile thing to be looking at. And what we could see is that there wasn't too much change between 2003 and 2020. Treatment completion rates were a bit higher for withdrawal management, sitting up around 70%, whereas it's closer to about 60% for counselling and about 50% for rehabilitation. And we're not sure exactly why that may be. It could be that rehabilitation is often provided in residential settings where people are away from their work and their families, and it's a more intensive treatment, so it may be more difficult to remain engaged all the way through the episode of care. Or it could be because the clients that are presenting to residential rehab services often present with more complex needs, more severe patterns of substance use, and so they may have more barriers to remaining in care as well. Or it could be a different reason. So overall, I guess this study gave us a bit of an overview of what drug and alcohol treatment looks like broadly for young people, with episodes of care mostly focusing on cannabis and psychostimulants. And we can see that in Australia, treatment completion didn't change too much over this period that we looked at. And the completion rates for some type of treatment weren't that high. So the next thing that we wanted to do then was look broadly across the existing literature and try and understand what the published literature said about treatment completion among this group, what might predict treatment completion. So to do that, we next did a systematic review, and we were looking at psychosocial drug and alcohol treatment completion among young people. We used a broader definition of treatment completion here compared to our previous study, because definitions did vary across different studies in the literature. So some of the studies talk about a certain number of sessions. If you attend, say, 10 sessions, then you're completed. Others used a specific treatment duration, like, you attend 1 month of treatment, then you're completed. And others used planned versus unplanned discharge in the same way that we did in our last study. So we included all of those different definitions in this review. In terms of our aims, we had 2 main aims for this study. The first one was to run a meta-analysis looking at the proportion of young people that were completing their episode of care across all of the included studies. And the second one was to synthesize the research that looked at correlates of treatment completion and what sort of factors seemed to be predicting completion of the episode of care. For our inclusion criteria, the study had to report on treatment completion or early disengagement. The population had to be 25 years or under. It had to look at psychosocial drug and alcohol treatment. So we weren't thinking here about withdrawal management or pharmacotherapies. We only included published quantitative literature, so not qualitative grey literature or reviews. And using that criteria, we ended up with a total of 98 studies included in our review. So firstly, from our meta-analysis, we found that across 88 studies, an estimated 59% of young people completed their episode of care. And this was a little bit lower than the treatment completion rate that was reported in quite a similar review that was done a few years ago in the adult treatment population that reported around a 30% non-completion rate, so about 70% completing. So I guess just highlighting that this population does seem to have some difficulty with remaining engaged with care. And for this analysis, we did group together the studies that were looking at adolescents only, emerging adults only, or both. But when we did pull it apart and do those meta-analyses separately, we didn't see any significant difference. So we've grouped those studies back together again for the rest of this paper. The next thing we did then was synthesize findings across all the included studies that were looking at what kind of factors seemed to predict completion of treatment. And the first thing we saw was that there was really limited evidence for demographic predictors of treatment completion. This is things like gender or age or clinical presentation. There wasn't a lot of evidence that those things seemed to be consistently associated with likelihood of completing treatment. One exception to that, though, was that we did see that in community-based treatment settings, clients that were white seemed to have higher odds of completing treatment compared to comparison groups. But that was kind of the only really consistent finding that we saw in this area. We also saw across a number of high-quality RCTs that family-based treatments, things like brief strategic family therapy or multidimensional family therapy, consistently had higher rates of completion compared to the comparisons, which were things like CBT, individual psychotherapy, or treatment as usual. We also saw contingency management, again, across a number of pretty high quality RCTs, as having higher rates of completing treatment compared to those same treatments, but without contingency management associated with them. And the final thing that we noted here was that most of the research looked at client-related predictors of treatment completion, so things like demographics or clinical presentations. And there was quite limited evidence on treatment-related factors, things like therapeutic alliance, client goals, service policies. And this felt really important because the treatment-related factors are the areas where services can make a difference. Services can't necessarily change the demographic characteristics of the clients coming into their service, but they can change the way the services are provided. So it felt like a pretty important area that there wasn't a lot of research at the moment. We also wanted to look at early treatment disengagement as, I guess, an alternative way of characterising retention in care. So rather than looking at whether someone completed their entire episode of care, we wanted to see whether there was a difference in the sort of factors that might predict whether someone drops out really, really early in treatment. Unfortunately, though, there was not very many studies that looked at early treatment disengagement, and there wasn't a consistent definition of what early disengagement actually is. So we weren't able to do any kind of meta-analysis or any more kind of work on that variable. So looking at these results, we saw that there was a limited amount of research on treatment-related factors, and there was also a really limited amount of research in Australia. So only 3 out of the 98 included studies were in the Oceania region, and only 1 of those was looking at treatment completion. The other 2 were looking at early disengagement. So the next part of the work that we wanted to do was to take a bit of a more local lens and try and understand what sort of factors might be associated with completing treatment in New South Wales. And we also wanted to make sure that we were accounting for some service characteristics as well as client-related factors that we often see in the literature. So that brings us on to our third study, and this study aimed to identify correlates of treatment completion among both adolescents and emerging adults who were attending non-government treatment services across New South Wales. For this study, we used routinely collected data from the database. And if anyone's not aware of the database, it's an online data system that's collected and managed by the network of alcohol and other drugs agencies. And they collect data on treatment episodes from their member organisations across New South Wales. So we were looking here at clients with closed treatment episodes between 2012 and 2023, and we ended up with a sample of just over 17,000 individual clients. For this study, we did break our analysis up and we ran separate models for adolescents in community treatment, emerging adults in community treatment, adolescents in resi treatment, and emerging adults in resi treatment. And we looked at multivariable logistic regression modelling to try and understand what types of client-related factors and treatment-related factors were associated with treatment completion. So this slide presents the results of that multivariable analysis looking at treatment completion among adolescents only. So this is not the emerging adults here. There were lots of different variables included in the models, but I've just pulled out those that were significant here to make it a little bit easier to read and understand. And if anyone's not familiar with odds ratios, the variables that fall onto the left of the dotted line means that those people were less likely to complete treatment, and anything that falls onto the right of the dotted line means that those people were more likely to complete treatment. So for adolescents, there was a couple of consistent predictors of treatment completion across both community-based services and residential services. The first was reporting polysubstance use pre-treatment, which was associated with lower odds of completing your episode of care. And the second was insecure accommodation, which again was associated with lower odds of completing treatment. This next slide shows the results of that same analysis, but here we're looking at emerging adults. And again, there was lots of variables included in the analysis. I've just pulled out the significant ones. For emerging adults that were in the community-based treatment, there was a number of variables that were associated with more complex presentations that seemed to predict lower treatment completion odds. So these included things like polysubstance use at baseline, criminal justice referral into treatment, insecure housing, and a history of injecting drug use as well. We didn't see these same patterns in the emerging adults who were in residential treatment, and we aren't sure why this was. One reason could be that the older young people, this older group of young people that are entering residential services tend to have more complex needs overall. So that kind of skew in the data may wash out some of the kind of the results that we're seeing. Or it may also be that residential services are, because they tend to be catered to people who have more complex presentations, may be more equipped to support people with those kinds of presentations, which again might dissipate some of these results. The consistent finding that we did see though for emerging adults in both the community-based treatment and in the residential treatment was that those people that were attending youth-specific services had much higher odds, almost 2 times the odds of completing treatment compared to those that were in adult services. So to give a bit of a summary so far, the results that we looked at so far, the studies that we've presented so far, looked primarily at treatment completion as the outcome of interest. And while this is important, there's lots of aspects of care that are not really captured by looking only at treatment completion. We also saw in this third study on this slide here that when young people, particularly emerging adults who are attending youth-specific services, a much larger proportion of them were completing treatment. But despite that, a significant number of these young people were attending treatment in adult services. And this is likely related to service capacity. You know, there's quite a limited number of youth-specific services, and people often need to seek treatment wherever they're able to get in. So I guess for that reason, it's really important to try and understand, firstly, a broader perspective on young people's experiences of care beyond just completing treatment. And also it's important to look at what their experiences of care are like when they're entering adult services, because a large proportion of them will need to enter adult services. So that kind of thought brings us on to the final study that we did as part of this body of work. And for this final study, we wanted to look at treatment satisfaction as our main outcome variable. And we wanted to look at treatment satisfaction among emerging adults who were attending general adult drug and alcohol treatment services. We had 3 main aims. The first was just to understand treatment satisfaction among adults versus emerging adults. The second was to examine the relationships between treatment satisfaction and things like perceived treatment outcomes, support for autonomy, and positive experiences within care. And then we also wanted to look at whether those relationships were moderated by age. In terms of our methods, we used a cross-sectional survey of just under 400 clients that were attending a New South Wales-based non-government drug and alcohol service. And we had 3 main measures that we were using. The first is the Client Satisfaction Questionnaire, the CSQ-8. And this is quite a widely used measure of treatment satisfaction. It's been validated and has some norming available in drug and alcohol treatment services. The second was the Healthcare Climate Questionnaire. And this is a measure of perceived autonomy support. So the extent to which clients feel that they're Autonomous decision making is supported, the extent to which they feel like they can be active participants in their own treatment. And the HCCQ is not so widely used at this point in drug and alcohol context. It was initially developed in the context of weight management interventions, but it has been used a bit in smoking cessation and mental health research. And it does have good face validity, I guess, for use in this population. And it aligns quite well with principles of person-centered care, which we know is really important in drug and alcohol treatment. So it seemed appropriate to include this measure. And then the final measure we used was the YES survey, the Your Experience of Service. And this is a really widely used treatment experience measure in New South Wales Health Services. And it has two main subscales. The first is perceived treatment outcomes. So do people feel like treatment is making a difference? And the second is positive experiences in treatment. This is things like perceptions of safety, respect, and communication in care. So for our analysis for this study, basically we wanted to get those treatment experiences, the perceived autonomy support, perceived treatment outcomes, and positive experiences in care, see if they were predicting or associated with treatment satisfaction, and then see if those relationships changed depending on the age group of the client. So what we found, firstly, when we compared treatment satisfaction for the emerging adults and the adults, was that the emerging adults had overall lower treatment satisfaction compared to the older adult clients. We didn't see any difference in the other variables like perceived autonomy support or experiences of care. And although the difference in satisfaction may appear small with a median score of 26.5 versus 29, we know that treatment satisfaction measures tend to be really skewed toward positive results, which might be related to perceived pressure to respond positively, difficulty giving negative feedback. The questions might not capture aspects of the client's experience that are negative, or it could be other reasons. But the result is that what looks like a small difference might actually reflect a clinically meaningful difference in treatment experience, with young people's needs not being as well catered to as the older adults in care, who are the majority in that service. In terms of our moderation analysis then, as we would expect, we saw that perceived autonomy support was positively associated with satisfaction. Perceived treatment outcomes were also positively associated with satisfaction, and positive experiences of care were also positively associated with satisfaction. What we saw was that there was no moderating effect of age group that we observed. So these relationships seem to exist regardless of the age group of the client. I do want to note though that the results here are cross-sectional, so we can't identify causation or direction. But what they do tell us is that aspects of care like support for autonomy, respect, communication, safety, seem to be related to treatment satisfaction regardless of client age, and that they're equally important for young people compared to older adults in care. Before I jump onto some of the final conclusions of the studies, I think there's a couple of key limitations that are worth noting. The first is that we did rely on routinely collected administrative data sets for a couple of these studies. And that meant that we got quite a generalizable representative sample of treatment episodes and of clients, but it also meant that there was a limited set of variables available, so we couldn't always control for all of the covariates that we might have liked to. This decision was made, I guess, in part because this is a body of work that we began right in the middle of COVID lockdowns, and we weren't sure how much face-to-face data collection would be feasible. But it does mean there's probably some variables that we'd like to account for in future research that we couldn't here. The other thing to note is that treatment completion was our outcome measure for a couple of the studies, and we know that that's an incomplete measure of successful treatment. It is an important thing to consider, but you do need to take a more broad lens as well and understand different kind of experiences within care, particularly in qualitative kind of research, which I think is an important direction to move toward in this space. And the third thing is that we didn't have a co-design element of this research. So we did work with service providers on some of the studies, which was really helpful to gain that kind of clinical perspective. But we didn't have young people collaborating with us on this research, which I think would have been lovely, and I think will be important in future research as well. So pulling together the studies across this body of work, there's a couple of key messages that really stood out for us. The first is the importance of equity in service provision. So the results of that NADA-based study showed us that kind of complex and intersecting needs, so things like insecure housing, polysubstance use, injecting drug use, criminal justice referrals, tended to be associated with lower odds of completing treatment. We also saw in the systematic review that ethnic minorities, another group who often face stigma and exclusion, were also less likely to complete treatment. And additionally, that final study found that the emerging adult group, who typically represent a minority in services and were a minority in that service, had lower satisfaction compared to the older age group. So I guess all of these results really point to the importance of making sure that people who might have a harder time with treatment engagement or who might have more barriers to treatment engagement are supported adequately. And there's lots of things that this may look like, and I think it's an area for further research and exploration, but it may look like having really active follow-up and aftercare processes, ensuring that young people have access to multidisciplinary support and wraparound care to help them navigate the treatment systems, involving family and other supports where it's possible, and also consulting with more marginalised groups on service provision and service improvements. And finally, introducing strategies like contingency management to support ongoing treatment engagement where possible. Another thing that really stood out here looking at these results was that in order to really improve treatment experiences and improve treatment outcomes for young people, we need more research that focuses on service and treatment characteristics. So the majority of the studies that we looked at in a systematic review were focusing on demographic predictors of treatment completion. And while that is important to understand groups who may be more at risk of disengagement so that they can be supported, it's equally important to look at the areas where services can have control and make change. And we did see in a couple of the studies that there was evidence that service-related factors do have a role to play. Specifically, we saw that family-based treatments and contingency management were associated with higher odds of completing treatment. And we also saw that young people who were attending youth-specific services where their needs are catered to specifically had much higher odds of completing treatment. And we also saw in the final study that policies like supporting autonomy, facilitating positive experiences of care were also associated with higher treatment satisfaction. So I guess all of this is telling us that there is a role of treatment-related factors, that we do need more research in this space. So before I finish up, a couple of directions, I suppose, for future research. The first is that I think we need a lot of qualitative research. A lot of the work that's been done is quantitative and uses quite simple outcome measures. And I think we really need to understand young people's experiences in more depth, and I think qualitative studies will allow us to capture that nuance. Another kind of direction that's going to be really important is co-designing youth-friendly service adaptations with young people, and then using implementation research methods and cost-effectiveness methods to understand whether those things are working and how they're working and how they can be implemented most effectively. And we also need some studies that evaluate the youth-friendliness of all drug and alcohol services, but particularly adult drug and alcohol services if they're accepting youth clients. We need that research using standardized tools so that we can have some kind of comparability and some consistency across the literature. And there are a couple of audit tools that are currently available in Queensland, Western Australia, New South Wales, and probably some others as well. So evaluating those audit tools and then implementing them in research is another direction that I think will be really important in this space. So I've got my contact details there if anyone wants to get in touch or reach out at all. And that's about it from me. So I might hand back over to Calvert.
Fantastic job, Meg. Thank you for that wonderful presentation and delivered it at such a high level. I'm just so impressed with the breadth of your work that you've completed over the span of your PhD. And you've really painted such an intuitive narrative to follow where you've worked towards understanding and improving service delivery for young people, which is obviously very under-researched. Um, However, before I keep ranting about it, what I'm going to do is invite Associate Professor Bryony Lawrence to please turn on their camera and if you would provide a reflection of what are your first thoughts as Meg's primary supervisor on that wonderful presentation. And before you do that, just reminding everyone, I can see there's a lot of questions already, but please keep putting them in there and I'll try to ask as many as I can.
I guess, Meg kind of hinted at this, but, just to acknowledge that the body of work was completed under really difficult circumstances, that Meg was finishing her honours year under the beginning of the pandemic conditions and commencing a PhD right at the peak of all of that era. And it was a very uncertain period around how to do a PhD and what sort of data sets to bring in and use. So, there are limitations with the data that Meg could work with, but I guess something that I'm very mindful of and that we probably need to think about with a lot more nuance is around, how we measure a good treatment outcome generally. We use this sort of proxy measure of treatment completion in the work that I was involved in with Meg. But Meg, I'd be also really interested in hearing your thoughts on what you think we should be thinking about in terms of measuring sort of successful treatment and good treatment outcomes. Yeah.
Oh, there we go. I'm off mute now. Yeah, I think you're absolutely right that treatment completion and even satisfaction is not quite nuanced enough. It's a good start, but it's not quite nuanced enough to really capture whether this treatment should be considered successful. I think that using client experience measures is a really important, one really important area to understand the quality of the care that they're receiving. And I also think that taking kind of a individualized or a person-centered perspective and understanding for all your young people in care, what are their specific goals and whether those goals are being reached in treatment rather than necessarily imposing a goal like treatment completion or abstinence or those sort of rigid measures.
I might even jump in here, and my PhD was similarly on AOD treatment using linked data. And one way we approached it is by using administrative data as the outcome. So I think there's many ways to do it. And I think the main consideration is around we're working in such a resource poor environment. So it's not just about what's the best way to do it, but what's the feasible way to do it. And I think your work really contributes to understanding that. And I agree with all of your conclusions as well. It really is about those treatment factors, not just about what happens in treatment. That being said, David Deneur has asked, was there a specific modality or theory that had better outcomes than others for young AOD? Something I was wondering as well was, is treatment modality uniform?
Yeah, so I guess I'm going to be referencing this systematic review that we conducted in this. And the first kind of treatment modality that we looked at was residential treatment versus community-based treatment. And in those different areas, we didn't see a significant difference in the proportion of young people that were completing their episode of care. In terms of more detailed, I suppose, approaches to treatment, the main things were family-based treatments seemed to be associated with having more likelihood of completing your treatment episode. And also, even when treatment wasn't necessarily a family-based treatment, there was a couple of studies, not a heap of research, but a couple of studies that looked at non-family based treatments and found that if family was involved with the treatment, they also had more likelihood of completing care. So it doesn't necessarily have to be a family therapy in order to bring in supports and for that to be helpful.
Thinking about that has really important implications for a whole range of, I guess, different communities. I know, for example, in working with cultural and linguistically diverse communities, it's really important to involve families, and it kind of provides some evidence of the effectiveness of doing that.
Yeah, absolutely. And just going on from that question, I wonder if there was did you investigate the model of care that was given within each modality? For example, residential has maybe therapeutic community is a really common one that's cited. I wonder if you looked into that.
Yeah, for these ones we didn't. We grouped together the therapeutic communities, the inpatient stays, and the kind of standard residential care. We did the same in the community-based treatment. So we don't have that level of nuance, but yeah, the broad level we didn't see a difference.
And unfortunately, in those sort of routinely collected data, at least in New South Wales, you don't always know exactly the, sort of philosophy or framework that the clinicians are working from in terms of delivering individual care. So you can't examine it in that way in those data sets.
Yeah, and even sometimes when you have contact, sometimes the record keeping doesn't even capture what is being delivered. It's definitely improved more recently, but yeah, it can be hard to track that down sometimes. Just a very quick question. Someone was asking what the main psychostimulants were in the trends data, I'm assuming from study 1.
Yeah, so I think from memory, I'd have to go back and look at the nuance on this data, so don't hold me to it. But there was a decent chunk of young people that were using amphetamines and methamphetamines. It was not as common to have the cocaine type stimulants. We were more seeing the amphetamine type stimulants from memory. Do you think that's right, Ryan? Does that sound right? Yeah.
Yeah.
That's what I was thinking you'd say as well. Chloe has asked, could you speak a little bit more about what specific characteristics or practices are emphasized in youth-focused treatment that might be missing from adult treatment, and whether it would be feasible to integrate similar practices within both of these settings, given so many youth go through this pathway? That's a great question.
Yeah, I think it could be a whole range of different things, and in some ways it's kind of going to be difficult to integrate, because I think one of the things about being a young person in an adult service is actually the experience of being a minority in that service. Being so much younger than most of the other people that you're there with, they may be in a completely different life stage. It's much harder to relate to those other clients who are in the service, particularly if you're in a residential service. Where in a youth specific service, you're around people that might be going through similar experiences, and you've got more of those relationships to build on. So I guess that would be really difficult to change in an adult service. You can't just drag down the age range. But some other things might be thinking about supporting young people in terms of their identity development, their transition into the workforce, feeling like they are capable and competent, and moving into adult social roles. Those transitions that a lot of adult clients might already have done, already have navigated. I think those are really important things to be considering when you're working with young people that might be missing in some adult services.
I wonder if this bleeds into the social aspects of family that you were talking about as well. There's a bit more social disconnectedness as well when you're maybe have an age gap. I don't know, Brian, if you want to add anything onto that.
Yeah, and I was also thinking, so yes, absolutely, there's something around the role of services helping young people enhance those positive networks that can build their social capital and resources to be able to access health systems and complex kind of, the system is complicated. It's complicated as an adult. So, I could barely interact with the Centrelink website. So I can't imagine what it's like as a young person kind of grappling with all of that. So there's absolutely a role for services kind of around helping build social supports for people generally, and it's an area of research we're really interested in here at the University of Wollongong, regardless of their age, but I think especially for young people. I also, I guess, was thinking more broadly around one of the key things that I think we need to get better at is sort of focusing our services to make sure that everybody leaves with a sense of hope for the future. And I think that's particularly important for young people. So that idea of building their confidence and skills in treatment is really essential. And I think that also carries through all our treatment populations as well. So if you're taking a universal approach, I think those two things would be really helpful.
And I definitely agree with that. Changing topics a little bit now, Antonio has said, lovely talk, well done, which I agree with as well. What do you think it was about regional services that made them have an increased likelihood of, I believe it was treatment completion? And following from that, what would you suggest an outreach youth-specific service could do to superpower their treatment effectiveness? I'm sure that's $1 million question, but have a go at answering it.
Yeah, I think that was in the NADA-based study that drew on non-government organizations and was kind of looking at across the state what treatment completion kind of looked like. And we did see in some populations that those regional services had higher completion rates. It's hard to know why that may be. And I mean, one conclusion could be that it's, there's a couple of services in regional areas, and those specific services might have practices and policies that are really helping their young people to remain engaged. So it may not necessarily be the fact that it's a regional service. It may be that those services might be doing a really good job and that they're kind of skewing the data. In terms of outreach and what outreach services could do, I think, as you say, it's probably $1 million question. But I think that really active aftercare and active follow-up, active outreach is really important for young people who may not have a lot of support necessarily to continue to engage with services or to contact services. They may not know how to or feel confident to reach out to a phone number or a website or a contact. So having outreach workers that can kind of take that burden off of them, I think, is one really important thing for young people.
Bryony, did you want to add to?
I can't add to that. I think that's a great response.
Yeah. So Jason Ferris has said, nice to see joint point being used. I'm not too familiar with that myself. They noticed in the alcohol series, the two youth groups tended to show decreasing trends in the early 2010s. However, adolescents continued to decrease while emerging adults flatlined. And they were just wondering what your thoughts were on that and whether it could be linked to the decline in youth drinking. Caitlin agrees.
And I'm nodding. I would agree with that too. I think that's a pattern that we're seeing across a whole range of different data sets, including, what people are accessing treatment for. It's definitely consistent with data and patterns of drinking in young adults generally.
Yeah, I actually wrote that in my notes as well. It's nice to see that your data is actually aligning. Your trend data was aligning with other sources of data that I've seen as well. And yeah, what are your thoughts on it, Meg?
I mean, I think I absolutely agree with you guys. I think one of the things that it was a nice finding in some ways to see that, when I was looking at the data, I was like, oh, these alcohol trends seem to be going down, and looking at whether that is whether youth drinking is declining, because I was, a part of me kind of worried that we might be seeing people seeking treatment for alcohol use less, but that they may not be drinking less, and that it may be a change in kind of normalizing binge drinking or normalizing excessive use of alcohol. So seeing that it was aligning with, a reduction in alcohol use in the communities of young people, I think was a really kind of hopeful thing to come out of this study.
Thank you. So this is actually a question I was thinking about as well. Janelle Rooney has asked, did your investigation of polysubstance use include smoking or vaping? Given it's 2020 pre-data, I'm imagining it would be more smoking or just general nicotine use. Or did you look at it separately to polysubstance use? Given that a lot of AOD services are smoking free, how would that have impacted treatment completion? Just adding on that sometimes there can be punitive measures taken for smoking.
Yeah, I think that's a really good point, particularly thinking about treatment services often being smoke-free environments, and that if you've got someone who is smoking regularly or vaping regularly, then going into treatment and having to cut back on that is going to make treatment quite difficult in some ways, and it's going to make it maybe more difficult to remain engaged. When we were looking at polysubstance use, when we were kind of conceptualizing what that was, we weren't including nicotine in that, and we also weren't including things like caffeine or gambling. So we were thinking specifically about, I suppose, the types of substances that you'd typically see people presenting to treatment for.
Did you want to add on to that?
I was just thinking as well, and I'd love to have known whether policies played a role in that. It's just something that isn't captured in a way that we could analyse in New South Wales. But there's a whole study just on that exact issue, I think, particularly for young people in treatment.
Yeah, I mean, it would be really interesting to see how that landscape has transformed with vaping, which can maybe be a bit more incognito, and how policy has evolved as well. Um, Probably have time for one more quick question. Contingency management is probably not a quick question, but your thoughts on why it's not more widespread given the evidence of effectiveness that was found in your systematic review.
Yeah, I think it's probably quite a complex issue. Yeah, our systematic review that we did find that it had higher rates of treatment completion, and there's quite a broad body of evidence that suggests that not just for young people, but in drug and alcohol treatment, it tends to support ongoing treatment engagement and abstinence if that is a goal. I think there's often difficulties with clinicians' perspectives on contingency management. Some people have concerns about whether it's should be used, whether it's appropriate or ethical to use. And I think also it's difficult to implement without having broad service level policies about contingency management. It might be quite difficult for an individual clinician within a service to start using that type of treatment approach if it's not widely used within their service or within the sector.
And I think it's an area which is very much a topic of interest. I'm aware of work within our own Centre for Research Excellence where people are looking at exactly this issue around the sort of barriers and facilitators of contingency management for young people in treatment. So there's this work being led up in the University of Queensland at the moment that's seeking to answer that exact question.
Amazing. We do seem to always get a contingency management question during the treatment webinars. I'd like to thank you so much for both joining me. You were such a wonderful presentation, and your thesis will be amazing based on the presentation, and the work you've completed is very impressive. And thank you, Bryony, for joining as a panelist. Now, before I let the audience go, I'm just looking quickly to the future. If there's a slide. We do have a Easter or public holiday next week, so there will be no webinar, I believe, until the 1st of May, where we'll be looking at alcohol advertising in disguise and how exposure to zero alcohol products and promotion drives adolescents' perception of alcohol with Dr. Ashley Bartram from the National Centre for Education and Training on Addiction. And just a quick reminder that our symposium, which is on the 26th of September, yeah, you can now register for that. So if you're around Sydney, then please do come. We'll be presenting a lot of NDUX work there. Thank you all for joining us, and we will see you in May.